And just a quick, Ed had a nice introduction there. Just a quick background on me. As it said, I'm trained as an economist, so I have relatively limited medical knowledge and clinical knowledge. So, a lot of my research is trying to address large data sets and make sense of perhaps population health issues. And so there's a large focus of my research. And so today, what I'll try to do in the discussion is to kind of give a quick whirlwind tour, if you will, of the research that we've done on hurricanes Katrina and Rita on child and senior health outcomes. I'll talk a little bit about the limitations of the analysis, what we can't say based on our work, and then at the very end, propose potentially some takeaways that we can look as results of this research. A couple of acknowledgements here at the outset. I want to acknowledge the support by the Eunice Kennedy Shriver NIH Center and the National Institutes on Aging for funding this research. And as the slide says, the comments today do not represent the official views of the NIH. Okay, so quick background. First off, I already saw this morning I had the wrong date. The Hurricane Katrina made landfall in Louisiana in the summer of 2005, obviously. What's interesting about Katrina was it actually went through, some of you may be especially familiar with this, but it actually crossed Florida early on its path. So August 25th, it made landfall in Miami. Actually had quite a bit of damage in Florida. 1.4 million people were without power, over $500 million of damage. Then it entered the Gulf. It reached a Category 5 status in the Gulf. But by the time it made landfall in Louisiana on August 29th, it did fall to a Category 3 hurricane. As it says there, almost 2,000 people were killed, which places it in the top 5 natural disasters in the U.S. And property damage was in excess of $80 billion, which to this date is still the costliest natural disaster in the U.S. Then Hurricane Rita came roughly 4 weeks after Katrina. It's often not remembered very well, but it was a very taunting or dangerous storm at the time. It was made the highest wind speeds in the Gulf ever. The observed wind speeds of Katrina hit 180 miles per hour. Again, it did fall in intensity somewhat by the time it hit the Texas-Louisiana border. And it also had a bit of deviations passed towards the end. It was expected to cross over Houston and led to lots of evacuation issues. And actually, a large number of the 125 people killed were actually died in traffic jams trying to get out of the Houston area. But again, the hurricane took a slight deviation when it hit the coast and went east, closer to the Louisiana border. That being said, as it says there, over $18 billion of property damage were attributed to Hurricane Rita. Okay, so obviously 2 large storms, and not surprisingly, there's been a substantial amount of research on the storms and their effects. As it says there, most of the emphasis, though, has been on short-term effects. Lots of it's been on access in the sense that what were some of the barriers that those affected by the storms faced in trying to get health care. Some of the research was performed on outcomes, but the vast majority of it was survey-based in the sense that they consisted of asking individuals after the fact what their experiences were, potentially what healthcare they did or did not receive, and were based on survey administered findings. And the general results of those research was, increased rates of acute and chronic conditions. So we'll see in the later discussion some of the issues along those lines that we found, and also, not surprisingly, large barriers to access, both in terms of medications, but also obtaining providers and reaching hospitals and so forth. So the 2 projects that we've embarked on looking at these 2 storms look at 2 different vulnerable populations. First, we look at children, and we're investigating children enrolled in an emergency Medicaid waiver called TextCap. And so as a quick means of background, Medicaid has emergency waivers, and again, some of you listening may be very familiar with these, can institute emergency waivers following natural disasters. And those waivers allow for a short-term coverage that can adjust the different criteria by which people can obtain coverage. So it might raise the income level. It also, under these emergency waivers, can waive some of the paperwork requirements that are typically administered with Medicaid. So these kind of short-term insurance coverage through Medicaid. And again, this first branch of research in children looked at children enrolled in this TextCat waiver, which was the Texas emergency waiver. And the TextCat waiver was actually the largest in the country. It provided roughly 6 months of coverage, and it ended in June 2006, so a little bit less than a year after after Katrina hit. In that branch of research, we looked at 3 different types of conditions: diabetes, asthma, and mental health, and we'll talk about our findings in those 3 areas in a second here. And the other main branch of our research was on seniors, and we focused largely on those with diabetes. And in that context, we looked at both maintenance screenings, in other words, screenings that would be in regards to routine condition maintenance of diabetes. We also looked at emergency department visits and hospitalizations. And finally, we examined mortality. So the data we use, I think, is arguably the part of the innovation that hopefully gives us some insight into what happened. So we use Medicaid and Medicare data. So administrative data, in contrast with the previous research, which largely used survey data. And by no means are Medicaid and Medicare data perfect, but they are arguably somewhat better in terms of they are not subject to recall bias. So we have, clear data in terms of when individuals, for instance, received healthcare, when they were diagnosed with conditions, whereas with survey administered data, you can have the issue of misremembering or not remembering certain events. Also, with the administrative data we use, we have precise values and the exact dates and number of visits. So we think that gives us arguably a better insight into what the healthcare situation was relative to our survey data. And also we look at the longitudinal aspect of our data. So we're able to track individuals over time, and especially with the senior analysis we'll talk about later, and give us some context hopefully into long-term effects of the storms. It says that we have 4 main branches of data: enrollment data, that includes demographic data, age, gender, race, ethnicity. Claims data gives us information in terms of the actual services provided in both hospital and provider settings, but also in terms of prescription medications. And we also see in addition to the healthcare provided, we also see diagnostic information that's been recorded during those visits. Comorbidities, those track different chronic conditions that the individuals may have. And what we use in this context, especially in the seniors analysis, is a algorithmic setup for different comorbidities. There's the Centers for Medicare and Medicare Services in their data track, I believe it's 27 different chronic conditions. And these conditions are defined very precisely in terms of how to determine if an individual has that condition. So it's a very, I think, objective measure by which we can see, does the individual appear to have also another condition that we may want to take into account. And finally, you see we use mortality data through the National Death Index. Our all-cause mortality is through 10 years roughly after the storm, so through 2014. Our cause-specific mortality, so the deaths by specific causes, are only available for roughly a year after the storms hit. Here's a map that, for us, try to clarify in terms of how to assign individuals to different impact levels. So you see here a map of Texas, Louisiana, Mississippi, and Alabama. And what we've done is we've defined the affected and control subjects by the FEMA assistance level that's been assigned. Again, many of you in the audience are probably very familiar with this, but FEMA can, after a disaster hits, can assign certain levels of assistance that areas, and specifically counties, can receive. So either the dark red areas, those were defined as being deserving of individual assistance level. And so the definition for those areas are disasters effects in these areas are of such severity and magnitude as to be beyond the response capabilities of the state, affected local governments, and other potential recipients of supplementary federal assistance. So these are the hardest hit areas. You see in orange, those are areas that were, or counties, I should be more precise, counties that were defined as public assistance areas. This is a little bit lower level of assistance. There are different project categories, but again, it's areas that were affected by the storm, but not to the extent that the individual assistance levels were deemed. And then finally, the yellow area you see, those Alabama counties, those were not assigned any assistance levels. So those were, you'll see later, we classify them as generally our control group. One thing that might be a little bit confusing about the map is how the entire state of Texas was assigned, besides the individual assistance level, the remaining counties were all assigned public assistance levels. And that was through because of Hurricane Rita. thinking there was that the reader was going to have potentially an impact on those areas, and so those were assigned the public assistance levels. So let's dive into the results of our analyses. So the first aspect we'll look at are for children, and in this instance, diabetes. And so you see the citation there. As I mentioned earlier, we looked at different screenings for children with diabetes. We looked at HbA1c screenings, looking at in other words, the blood sugar level. Microalbumin, that's the sign to screen where if that albumin is found in the urine, is a sign of potential kidney disease. And we looked at complications as well. So we looked at DKA diagnosis, that's a diabetic ketoacidosis. That's when the body can't produce enough insulin, and high levels of ketones are found in the blood system. And what we've done, and you'll see this is a very common setup in different analyses, we define different time periods to try to assess the effects. So you see here for our analysis in this paper, we looked at our pre-Katrina period from January of 2004 through August of 2005. Look at the TextCat period, in other words, the time period during which the supplemental insurance coverage was in effect from September 05 through June of 2006. Then we have a roughly 6-month post-TextCat period from July 06 through December 06. Okay. So what do we find? Let me try to walk through this table a bit. So we have here the 4 different measures, the HbA1c, microalbumin, thyroid, and DK diagnosis. Within each test, we're looking at the 2 groups, a TextCat and a control group. N represents the number of subjects in those 2 groups. And then, as I mentioned earlier, we looked at these 3 different time periods for each screen. So the prior to Katrina period, during TextCat period, and the post-TextCat period. And these proportions here represent the proportion of subjects in those groups that received the screening or diagnosis in question. And so what we're looking at in the pre-period, a reason to look at those data is to see, are these 2 populations arguably somewhat similar? In other words, if these 2 proportions for the different tests are roughly similar, we could take some comfort that the TextCat group was analogous to the control group prior to the storm. And if you look for the across the different screens, we'll see that, again, it's not perfect. Don't expect any data to line up exactly consistently, but see that in the prior to Katrina period, those proportions are relatively same across the 4 different subjects. The during TextCat period is where we might expect some differences to emerge. And what was somewhat surprising to us in this analysis was for the blood sugar level tests, that actually was not any difference during the TextCat period. So even after the tremendous displacement and stress of the storm, that screening was not, did not experience any significant downfalls during that time period. For the other 2 tests, we did see some drops. Don't have the statistical notation here, but those drops were statistically significant. But then the post-TextCat period was actually a period that we were surprised to find arguably the worst outcomes. In other words, you'll see during this HbA1c period, the proportion of children who received the HbA1c test actually was much smaller in the TextCat group relative to the control group. We'll see that that trend was consistent in both the microalbumin and the thyroid tests as well. So our concern after this analysis was that, well, it looks like TextCat did pretty well during the storm period, but it looks like there might have been some drop off after the storm. And then our last category here, the DK diagnoses. Again, the DK is a diagnosis, a sign of diabetes that might be out of control. We'll see that the prior period was very similar. During TextCat period was somewhat higher, but there was a little bit more of a gap that was emerged after TextCat. So again, we have this concern that perhaps the coverage performed well during the aftermath of the storm, but it's not clear after the coverage ended that the kids in this with diabetes did receive the appropriate care. Okay. Our next analysis that we took part in was to look at the effects of the storms on children with asthma. So this is a paper in Journal of Asthma, and we looked at both medications and encounters. So for prescriptions, we looked at controller and quick relief medications. So ideally, controller medications are given to children to keep their asthma, as the term suggests, under control. Quick relief is some of a last resort where the child is experiencing very strong symptoms and needs immediate relief. And we also looked at different types of encounters that these children may have experienced. So inpatient, emergency department, outpatient, inpatient. And we've made a little bit more distinction within the subject groups. We have the TxCAT group, which again is the group that we would argue is most affected by the storm. Then we also looked at two different Louisiana groups. A Louisiana group that were in counties that were assigned as an individual assistant level, and then that we denoted as LA disaster. And then the remaining counties in Louisiana, we define them as being the non-disaster counties. And finally, we looked at the remainder of Texas as potential control groups. And this is more of a graphical analysis of our findings. So you'll see in the vertical axis, we have the proportion of subjects who had the prescription filled. And you'll see the two panels here represent the two different types of prescriptions, controller versus quick relief. And we're looking at here the two time periods. We left out 2005 in this analysis because of the concern of the quality of the data, especially for prescription data. So we look at 2004 versus the 2006 proportion of subjects who had a prescription. And we'll see this is a pretty worrying finding for the TxCAT. We'll see that from 2004 to 2006, that proportion fell from roughly, say, 0.38 to 0.28. Whereas for the other groups that were arguably less affected, those proportions were relatively similar, if not even increased for the Texas group. That being said, with that finding, we anticipate perhaps an increase in the proportion of children with quick relief prescriptions filled, given this concern that they were not able to adequately control their asthma, but we did not find that. So this is one of those instances where the data did not correspond to what we expected. So we see here that actually the TxCAT group also experienced a drop in the proportion of children who had a filled prescription for quick relief medications. Now we'll talk later about some of the limitations of the analysis, but maybe that does still represent or reflect issues for children obtaining the proper medications. So this is the medication analysis. As I mentioned, we also looked at encounters, their interactions with the health system. And so you see the top panel, we looked at office visits, and then the lower panel, we look at emergency department visits. And the vertical axis here measures the average number of visits within that group. And the office visits, you can see, has a very stark decline for the TxCAT group, from roughly 1.4 visits per subject in 2004 to roughly 0.5 in 2006. And again, to try to get a feel for if that reflects some other factors, we again compare that change to those other groups, and we see that the TxCAT group was much bigger drop than for the other groups that we analyzed. And again, we see that larger drop again present for the emergency department visits for the TxCAT group. So again, one of the big takeaways for us is 2006 period again highlights the potential for children to have left the TxCAT coverage. And our concern is that, based on these results, we might see this issue of children who potentially had decent or had adequate health care during the storm, but then in the year after, maybe did not maintain the adequate health care that we'd want. Then our last and third analysis in terms of children is to look at mental health utilization. And so this is a paper in Psychiatric Services. And our key here is that our sample is limited to subjects with one or more diagnoses in 2004 for a psychiatric condition. Okay, so again, we're limiting the children to those who've had one or more diagnoses in the data in 2004. And see that we're again looking at both medications and encounters, the prescription types. This is a subset of the ones we looked at. We looked at stimulants, antidepressants, mood stabilizers, antipsychotics. Again, you'll see among others. And then see those four types of encounters: psychiatric service, physician office, emergency department, and inpatient. And just to clarify, the psychiatric service category, that consists of outpatient psychotherapeutic services not provided by a physician. Okay, so again, perhaps a visit to a psychiatrist. And here we have our data in terms of a table. And as the title suggests, we're looking at the proportion of children with at least one filled prescription for the psychotropic medication as indicated in that class. And we're looking here at the first half of 2005 versus the first half of 2006. Again, we're trying to eliminate that period in the second half of 2005 when the data may be especially problematic given the aftermath of both Katrina and Rita. And the way the table is set up, we have in this first column the different classes of medication. The first row here corresponds to all the medications lumped together. Then you see the subclasses. This column here that I'm highlighting is the change in the text cat group. So in other words, it gives a measure of the proportion change for children from 2005 to 2006 who had at least one filled medication for that type. And this column again represents the text cat group. So we see, for instance, that for text cat children, the proportion of children who had at least one script filled from 2005 first half to 2006 first half fell by roughly 0.2. Then to the right, we have the three control, or the comparison groups, I should say. So LA disaster, again, these are children who did not move in Louisiana that were in a affected area. And we see for that group, the drop in prescriptions was roughly 0.12. LA non-disaster, these are counties that were not deemed disaster individual assistance areas. You see that roughly, the drop of roughly 0.1, and then Texas, roughly 0.06. Okay, so first impression might be, well, why are these all negative? Well, this generally represents potentially treatment lapses for children who were diagnosed earlier. As time goes by, they may be prescribed fewer medications if their symptoms tend to alleviate. But what we're looking especially at, though, is the differences between these changes for across groups. So this p-value you see here for each of the three groups, this category represents the p-value for the test of whether the change in the proportion of children who received a filled prescription differed between the text cat group and the group in question. Okay, and so you see for the looking at all medications in this class, we see that the text cat group had a statistically significantly larger drop in the proportion of kids who received a filled prescription than the comparison groups. We see that trend is relatively consistent for stimulants and antidepressants. But on the other hand, there's some instances where it was not the case for sedatives and hypnotics. For instance, you see that there wasn't a statistically difference, although I think from a practical point of view, those are still large point estimate drops. But the takeaway from this slide generally is that there is concern that children in text cat did not get the prescriptions filled at the rate at these children did in these comparison groups. And then the next slide looks at the different types of encounters. And we see that, surprisingly for us, and heartily surprised, that the psychiatric services were relatively similar across the groups in terms of the change. In fact, we'll see that there are larger drops for the LA subsets. But the physician office visit, and this kind of reflects the finding we saw for asthma, seems to be a significantly different drop. So you see the drop for the text cat children was roughly 0.2, whereas for the other groups, the largest drop we see is roughly 0.8, and those are highly statistically significant. So unfortunately for, again, kind of echoing the results from this asthma analysis, there does seem to have been a relatively large drop for children going to a physician office relative to the comparison groups, which is a point of concern that we'll raise a little bit later when we talk about the takeaways from our analysis. Okay, so that wraps up our analyses of different effects on child health. Again, we looked at diabetes, asthma, and mental health. Now we're looking at seniors. And as I mentioned earlier, our analysis of seniors was focused exclusively on seniors with diabetes, so either type 1 or type 2 diabetes. And so the three analyses I have for this section of the talk, again, only refer to seniors with diabetes. And we looked, our first cut of this analysis was similar to the child analysis, where we looked at screenings. And so looking at cholesterol, blood sugar tests, microalbumin, retinal tests. And you'll see that one difference about the senior analysis that differs from the child analysis are these longer time periods. So you see our pre-period, we're using actually 3 years of data for the 2002 through 2004, and our post-period analysis, our post-period is for 2006 through 2008. And one of the large factors that allows us to have this larger time periods relative to the child analysis is just the difference in how Medicare and Medicaid operate. Medicaid is a relatively high churn type of coverage where individuals tend to move in and out of the coverage relatively frequently. And so it makes a longitudinal analysis more difficult. Whereas for Medicare, once a senior qualifies for Medicare, they're in Medicare essentially for life. And so we're able to have a longer time periods to track these individuals. Okay, so again, looking at screenings, and here we tried to come up with a little bit more refined groups to do our analysis. So we're again looking at the pre-Katrina state as our basis, looking at where these individuals lived before the storm, and looking at the FEMA declaration level for to define the impact of the storm on these groups. And you see here we have these different groups defined both on the level of assistance and also which storm. So treatment T1, that's our broader category that looks at any individual that was in a pre-Katrina state that had individual level assistance. T2 is a little bit more of a subset. We're looking at individuals who lived in Louisiana specifically before Katrina, are allowing for the declaration of either storm for Rita or Katrina to be at the individual level of assistance. Then we have here 3 control groups we're looking at, C1 through C3. C1 you'll see is Mississippi with public level assistance. C2 is Texas, public level assistance. And C3 now is probably our purest control group. We're looking at Alabama counties that had no declaration. So these are individuals who were arguably not affected at all by the storms. So what do we see here? Again, looking at a graphical analysis, and looking at now the on the vertical axis, the proportion of seniors who receive those screens. And we're looking at the left part of the graph, looks at the pre-Katrina period. So as a view as to whether this analysis is valid, we want to see, do the groups before Katrina appear to have been relatively similar? Now we have this gap for 2005 again with concerns that the 2005 data may not be socially reliable. And then we look at the 2006 through 2008 period. And that is the area where we would expect, if there is an effect of the storms, to see a divergence in the graphs, okay? So what do we see? Well, looking at the 4 sets of results pre-Katrina, we see varying results. So we see the cholesterol proportions were relatively similar across the 5 groups, I should say. By contrast, though, the retinal screens, we see there was some divergence. And so from 2003 to 2004, we see that changes in the proportion that were screened actually increased significantly within those 2 periods. So for instance, we would be less confident in any findings based on the retinal results because it does not appear that there was a consistency in the pre-Katrina period. The HbA1c and the microalbumin findings, you see there is some divergence as well. So especially with the group C3, again, it gives us some pause as to how confident we are about those results. But then the cholesterol group, as we said earlier, is a little bit more tightly bunched. What do we see in the post-Katrina period? Again, I'm going to focus most of the discussion on cholesterol since that seems to be our most plausibly trackable condition. The 2 treatment lines are these red and green lines, and we see that in the post period that these groups did experience relative drops in screening rates. So relative to the 3 comparison groups, especially with the C3, this is the Alabama no declaration group, we see quite significant difference in the post-Katrina period for that cholesterol screenings for the affected groups versus the less affected groups. Again, though, this is not a perfectly clean analysis. We have this concern about across the other 3 screens, whether they, again, were not representative given that divergence in the pre-Katrina period. That being said, we do see the 2 treated groups less, the differences in the proportion screened were significantly less than those other groups. So again, not especially clear-cut evidence, but is suggestive that there was a drop in screenings for those individuals in the impacted areas. Our next analysis was to say, okay, we looked at screens. Do you see any effects in the rates of emergency department visits and hospitalizations? Okay, and the outcomes we're looking at in this instance were says those visits and hospitalizations, and we cleaned up or we consolidated the groups a bit. We're looking now here in terms of the individual assistance, public assistance, and no assistance breaks down. So we're looking at those 3 groups. And you might ask, well, why, talking about long-term visits, why would we look in the long-term period for emergency department visits? Well, this is significant literature that has found that for individuals with diabetes who do not maintain good coverage in terms of maintaining their sugar levels and receiving treatments and screenings, that they do tend to suffer higher rates of emergency department visits and hospitalizations in the even up to 3 years following those instances. So we do feel like that is a important analysis, being we found those results earlier from other papers that showed that drops in treatment can lead to poor outcomes down the road. And this is more of a graphical analysis. Again, kind of same idea though. This is now in the first slide here, the average number of emergency department visits. And we're looking at those 3 groups: individual assistance, public and then no impact. And with the same analysis where we want to see in the pre-period how well the groups tracked in terms of, there's a specific type of test called the parallel trends analysis. We want to see whether these lines are roughly parallel in the post-period, or I'm sorry, in the pre-period. And I think arguably these are. The individual, this is the none, so these are the purest control group, if you will. And then the dotted line for public is overhashed by the individual line. We see these lines are relatively parallel. With that, we have some confidence looking at, well, how do they differ in the post-storm period? And what we're looking at, especially towards the end of the period, is somewhat of a closing of the gap between the no assistance levels and the public and individual assistance levels. And I don't have the statistical results on the screen, but actually those 2008 differences are statistically different for the public and individual assistance groups relative to the no assistance groups. And if you do a kind of a back of the envelope calculation, that difference is, again, this is a rough estimate, but roughly 21,000 additional ED visits for the groups in the public and the individual assistance levels than they would otherwise if that difference is due to the storm. So again, some suggestive evidence that the rate of ED visits did increase, especially during the end of this observation period. The next slide looks at average number of days hospitalized. We'll see again in the pre-period, very similar parallel trends across the three groups. In the post-period, we do see a somewhat of a increase, again, towards the end of the period, towards the 2008 and 2007 values for the individual and public groups. Again, it's kind of hard to see the public and individual lines separately, but they overlay each other. But you see that gap towards the end of the time period. That again is some evidence that there might have been a difference for those groups relative to the none or the no assistance counties. And again, we looked at this on a statistical level, and if you look at the calculations, that comes up to, in terms of days hospitalized, additional almost 380,000 days hospitalized for the individual and public groups relative to the none group. Again, we want to be careful here. We're not able to make a causal connection. We can't say that the storms cause that difference, but in terms of just the number of days hospitalized, that is roughly 350,000. And so a large number, I would argue, for those two groups. And finally, our last analysis was to look at mortality effects. And this is where we want to look especially at the long-term effects. So we try to, I would argue, look at the intermediate terms in terms of that 1 to 3 year period following storms. But with the mortality analysis, given we had the data, we wanted to see, was there potentially effects even 10 years later from the storms? And you'll see we followed a somewhat different approach here. We used a one-to-one propensity matching to try to, for every individual in the affected counties, match them up with an individual in the unaffected counties along different types of observable characteristics. So in terms of, it says there, for demographic characteristics, we tried to match them up in terms of age, ethnicity, gender, in terms of the type of coverage that they had from the, in terms of Medicare coverage, and also in terms of the chronic conditions. We thought that was an important analysis, or important aspect of the analysis, that we were able to match individuals in the affected and unaffected groups, also based on their comorbidities, which is, I think, important in that if there's a difference in comorbidities across the two groups, any differences in mortality that we observe later may really just be due to that difference in comorbidities prior to the storm. So again, we took the subjects in the affected counties, matched them to individuals in the unaffected counties, and we looked at different types of mortality. We see here, we looked at the all-cause mortality, and as I mentioned earlier, that type of mortality we had for roughly 10 years following the storm. So that gave us a relatively long perspective to look at. In contrast, the by-cause mortality, unfortunately, we won't have this data for roughly a year after the storm. But within those categories, we looked at those who died for which the cause of death was noted as diabetes. Then we also looked at major cardiovascular disease and nephritis. Another aspect of the analysis that we thought was important was to look at not only whether the subjects lived in an affected area at the time of the storm, but also to see whether there were any differences for subjects who were in the affected areas but then moved after the storm. So there's a big area of research in disaster analyses that tries to look at, well, what's the effects of moving after storms? And with this long time period, we thought this was a good opportunity to try to see if there's any differences among individuals who moved after the storm versus those who did not move. Okay, so this table has a lot of numbers going on. We're looking at our odds ratios. So we see here, for instance, the odds ratio for an individual for all-cause mortality, and the 1 month all-cause mortality was roughly a 40% higher odds than those who were in the comparison groups. Okay, so we see that for the 1 month mortality, we looked at both all-cause, then those 3 by-causes that we mentioned, diabetes, heart disease, and nephritis. And then we also looked at 1 year mortality, and those results are given here in this. Again, we had that 1 year mortality for those 3 causes as well. But then for 3 years and for the full period, in going through 2014, those data were only available for the all-cause mortality. Well, what do we find? Well, we see a relatively large effect, a large difference in that first month. I just mentioned that the odds are roughly 40% higher for those in the affected groups. And that difference is also persistent for the heart disease and nephritis, not so much for diabetes cause of death, but for heart disease and nephritis, we see an elevated level. But within that year, we see that the 1 year mortality does start to collapse over time, so that 1.4 odds ratio falls to 1.1 when you look at 1 year mortality. Likewise, the heart disease and nephritis odds ratios both fall as you extend the period to a full year. And looking at by-cause mortality, this is the data for which we have for the 10-year period, we said it also decreases somewhat as you extend the time period. So from 1 to 3 years, the odds ratio falls from 1.1 to not a huge fall, but does decrease. The point estimate falls to 1.09 roughly. But then it does apparently stabilize to some extent when you look at the full period. So if you look at the roughly 10-year period, the odds of dying for someone who was in one of those affected counties is roughly, the odds are 10% higher than those for those who were in an unaffected county. Okay. So again, that decrease, the effect fell over time, but it was significant even by the end of the period. The bottom half of this table now breaks out the affected individuals by whether they moved or not. So this first set of results, the first row here, looks at all those who did not move to a different county. And you know here that 170,000 subjects, the vast majority of them did not move. And so not surprisingly, we see relatively similar results for the all-cause results for the entire group of individuals. By contrast, this next row looks at individuals who moved to a different county. Okay, so that makes up that difference at roughly 8,600. What do we see here? Surprisingly, we don't see an effect in that first month. Okay, so that was surprising to us. So there's no there's no significant, I should say, statistically significant effect for mortality for those who moved, and if within the 1 month time period. We do see a difference now emerge in the 1 year time period. Okay, a little bit of a contrast. But for us, the most interesting results were these last 2 columns, that unlike the results for the individuals who did not move, those elevated risk levels were relatively persistent and even grew somewhat in the 3 and full period time, or 3 and full time periods. So again, whereas for the individuals who moved, that mortality effect dissipated somewhat over time, for those who did move, that effect persisted. And we broke that up even further. We said, well, what about individuals who moved to an affected county? So they moved also to another county that was deemed having an individual assistance level, and then looked at individuals who moved to an unaffected county. And we see actually pretty similar results in those 2 groups. We see the higher effects, the higher odds ratios for those who move to another affected county. The point estimates are higher. I'm not certain they're statistically significantly higher, but they are high. It wasn't, I guess in that sub-analysis, we were interested, well, maybe that movement to an unaffected county is really the key to helping reduce that mortality risk. And our takeaway from this is that it really did not. It still has a relatively higher persistence of mortality risk relative to the those who did not move. Okay. So with all those results, let's first, well, I shouldn't say first, but let's talk about some of the limitations, and then finally we'll touch on some potential takeaways. So limitations, it says that we don't know their location at the precise time of storms. All of those pre-Katrina or pre-storm locations are based on their location as of January 1 on 2005. So if they moved during that time period, we don't know that, so that's one limitation. As you mentioned earlier, there's concern regarding the data immediately after the storms. A lot of individuals may have received treatment or prescriptions from entities outside of Medicare that were not covered by Medicare or Medicaid, so that might have been lost. Coding and professions, those of you who worked with claims data are familiar that coding is definitely less than 100% accurate, and so there might be some issues there. I mentioned earlier this idea of Medicaid churn, where individuals move in and out of Medicaid, and so that made it difficult to follow individuals for a long period of time. Next, this is an important one for the Medicare analyses, for the seniors analysis. We don't have data for Medicare Advantage enrollees. All of the analyses were limited to individuals who were in the Medicare fee-for-service program. And there is research that shows that there is some significant differences across those two populations. And so our results can't speak to the Medicare Advantage population. We weren't able to separate the effects of Katrina and Rita. Obviously, that 4-week interval between the two storms and the overlap of the counties makes it not possible for us to have pointed the results to one storm versus the other. And lastly, the historic extremity of Katrina. It's one of the things that we always try to emphasize is that Katrina was a it was an outlier storm, in that we don't want to convey or to portray, I should say, portray our results as being similar to what we'd find for any other storm. Katrina was a very historic moment. That being said, as we saw Hurricane Dorian come nearby at a very high level, if that path had varied somewhat, we could have seen a very large impact in the U.S. as well, that storm. And so while we don't want to claim that every storm has the potential impact that Katrina had, it is also the case that storms tend to be, larger storms can have roughly similar effects at least. So with all that being said, what are some possible takeaways? One of the things that we were really struck by in terms of the Medicaid analysis of children is the need to ensure that there's a good transition plan or extended assistance to enrollees in Medicaid emergency waivers. That drop in care for those children is troubling, in that there's a concern that perhaps we need to do more to ensure that those who were in those waivers were able to maintain that type of coverage after the waiver ended, or maintain adequate health care after the waiver ended. That being said, there was, for us, some interesting results that for some of the findings that we found reductions in maintenance or preventive care, we don't always observe negative repercussions from that. So is, I guess, some somewhat less concerning that they didn't have always these drastic repercussions that we potentially would observe. But that being said, we did see some effects, and obviously the need for preventive or maintenance care is of utmost concern. Also, our senior analysis especially noticed that, or highlighted potential differences that could emerge years after disaster. So for the child analysis, we saw some immediate effects, but for the seniors, if you recall, we did see drops in both ED visits, or increases in ED visits and hospitalizations as late as 2008. And so disaster research, we think, needs to make sure it's, when possible, take a long view, because these effects can emerge after many years. And finally, while we didn't see any effects of mortality differences after the initial shock, so that, remember, that dissipation of the mortality difference occurred, we are definitely intrigued and interested and think more research is needed to look at that difference for those who moved out of the impacted counties, especially if we think that if there's negative health consequences for individuals potentially moving outside of their counties after the storm, policymakers may want to consider steps that would either perhaps give individuals more incentive to stay in their home counties, and if it turns out that this type of result is persistent with other types of analyses. And that wraps up my talk. Thank you very much.
Thank you for a wonderful presentation. I'll give you a moment to look at some of the questions that came in during your presentation, and I would encourage anybody else to chat in any questions they may have.
Okay, so where will those questions be visible?
They'll be in your control panel, but I can go ahead and read them to you. The one question was asking why the 2005 data for asthma is in question. and if it would be possible to expand upon what that looked like. They want to know if there was could be a slide for that data, but I don't think you have that on hand.
Yeah, I don't. Yeah, and that goes back to that issue we had. So if you recall, our initial analysis, we include 2005 data, and we, be honest, received some pushback from individuals saying, well, that time period was of such, you know, trauma and stress, and there are lots of individuals receiving care outside of potentially receiving care outside of the coverage that would be reflected in our Medicaid data, that we really shouldn't rely on the 2005 data. That was the reason for not including that data in the asthma analysis. We wholeheartedly agree that that's important data, and if we had that data, that'd be arguably the most important data to look at, since that was in the immediate period after the storm. But again, we had concerns that the quality of our data were not very high during that time period.
Thank you. And then our next question is, are you planning to do further studies on other states with other hurricanes?
Yeah, so that was, I'm involved in some work looking at in Puerto Rico following the hurricanes in 2017 there, and trying to look at, especially in cancer care, looking at whether there are drops in utilization for individuals in terms of, for instance, the chemotherapy visits and whatnot. But yeah, we also have for us, I think the long-term aspect of this research is especially interesting. And so we're actually going to expand the Katrina, or pondering at least, expand the Katrina research to look at other facets of care to see if there are other long-term effects. But no, I know with Irma in 2017 as well in Florida, there have been some studies looking at, for instance, mental health effects of that storm. And that's the type of research we think is especially important. Again, we want to acknowledge that we don't want to draw any strong policy conclusions from just one storm, but we think that those types of analyses with, hopefully, again, administrative data, we think adds a lot of insight. Those types of analyses can give us hopefully some consistent results that we can then take action upon.
Perfect, thank you. I'm not seeing any other questions at this time. So unless any come in, I'm going to go ahead and give some information about our next presentation. And if no other questions come in, we can go ahead and end a little bit early today. So next presentation will be on October 8th, once again from 10 to 11 a.m. And we will be featuring Dr. Emmanuel Thomas. Dr. Thomas will be presenting on strategies to eliminate hepatitis C and to identify patients most at risk of developing liver cancer in Florida. To register for that webinar, you'll get an email link similar to what you did for this one. That'll be coming out in the upcoming weeks. And I want to remind everybody that September is National Preparedness Month, and that's why we want to have a presentation that focuses on hurricanes and the impact. I'm not seeing any questions, so I'd like to go ahead and thank Dr. Quast for a wonderful presentation, and I think we'll wrap up early today.
Great,
Thank you so much, everybody.
Thank you, and also let me put my email address on that first slide there. If anyone wants to reach out to me, I'm definitely happy to take any questions or comments. Again, my email address is troyquast@health.usf.edu.
Thank you, everybody. Have a great day.